Okay, hello everyone. So it's my pleasure today to introduce Matai Philippos. Matai should be a familiar face to many of you as he graduated from this department several years ago. Since then, he's been a researcher at Intel Research Seattle, and he's worked on a number of projects applying machine learning, in particular to human activity recognition tasks. So today, he's going to tell us about one of the main projects he's worked on, the Technology for Long-Term Care project. Matai.
Thanks, David. So it's a great coincidence that this talk is being given on the day of the inauguration of Barack Obama, because one of the big problems that he's identified, and people have identified for the last 10, 15 years, is that our healthcare system doesn't work. And in particular, the fact that our population is aging means that our system for taking care of the elderly doesn't work. It costs much more than we can afford. There's been a lot of talk, including, in fact, today, the inauguration, I think in Obama's speech, about applying technology to solve the problems of healthcare. Where there is perhaps little political will, technology might rush in to save people. But so my talk today is about what is this technology? So I've been working for the last few years on applying technology to the problem of caring for elders, and I'd like to give you a flavor of what this technology might be, what are the big pieces of it, and what's the road ahead. Before I start, I work at Intel Research Seattle. Hopefully most of you are familiar with the Intel Seattle lab. We are at 45th and 11th, very close to campus. About 20 people, I think a dozen or so researchers, and plenty of students, typically interns and visitors. We work a lot with the lab, and a lot of the work that I'm going to talk about today is actually being done by your fellow students. One of the so the focus of our lab is broadly on ubiquitous computing, and what that really means is, where sensors meet machine learning meets mobile networking. So we have a kind of competence in these things, and we tend to build systems that put it all together. And our fourth big competence is actually evaluating these kinds of things in the real world. So we tend to build systems that work in the real world, that put these things together. One of the good things is we have an open collaborative research model. So what that means for you is if you do research at our lab, you can pretty much always use it as part of your PhD thesis, for instance, and you can continue to collaborate with us, which is much more of a lightweight IP environment than other research labs. All right, having introduced myself in the lab, I'll just start a little bit with what do we mean by machines and care? I mean, when you talk about machines caring, sometimes, the picture that comes to mind is kind of scary. I mean, there is no real notion right now of machines caring, and what does it actually mean? So first of all, I'm focusing today on long-term care. And long-term care is really hands-on assistance with day-to-day activities. And this is really opposed to acute care. When you hear about telehealth, for instance, when you hear about technology in health, almost all of it is focused on acute or medical care, monitoring people's physiology. Here we are talking about day-to-day helping people with their lives. And once you are older than once you're above a particular age, 70 or so, let's say, long-term care issues start even dominating over many of the acute care issues. So here's a great excerpt from a great article by Atul Gawande from May 2007 New Yorker. And he is basically following one of his colleagues around who is a geriatrician. He himself is a surgeon at Harvard. So he's got a sexy job, and he's following somebody who's kind of less fortunate. He's merely a geriatrician, but he learned a lot. So one of the things that he figured out was when his colleague was examining someone, the patient's name is João Gabriel, he found out that she was in pretty good condition given her age. And given her age, pretty good condition means she had lots of problems. She had arthritis, a bunch of other ailments, including possible cancer. But after giving her a good look over about 45 minutes, his colleague concludes that the biggest threat that she faced was not the lung nodule, the cancer, or the back pain, the arthritis. It was actually falling. And in particular, because she wasn't taking good care of her nails, clipping them, and there was a risk of infection because she wasn't able to wash her toes very well, keeping care of her feet was actually the single most important thing he could recommend to her. And he recommended that she visit a podiatrist for that. So long-term care is something that we don't think about a lot, perhaps partly because we don't think about getting old that much. But it's actually a huge part of what you need to get by when you're old. Now, when you look at how we care today, This kind of schematic picture on the left says it all pretty much. An elder who might be in their home or in their apartment in some kind of a facility typically has their caregivers visiting them to provide care. Most often the caregiver is some kind of a family member, this person in green over here. Quite often a provider, somebody who's paid to go and take care of them. And in many of the cases, especially when there's government money such as Medicaid involved, there's a case manager that goes over there. And the fact that all these three people are over here near the elder is typically portrayed as a positive thing. It's a high-touch mode of care. They're all there kind of giving them support and care. And high-touch necessarily means, of course, high presence. And the moment you have either family members who have a job or highly paid providers and case managers being present somewhere, it really pretty much necessarily means high cost. So today's care really is high touch, high presence, and high cost. And in a nutshell, that's really why our care doesn't scale. And looking ahead, it doesn't look too good, because as most of you probably heard, this is a picture of the world. The purple and the deep purple parts are where there's going to be more than 30% of people over the age of 60, I think in 2010. And the big message there that we've all heard is that the world is aging. And the big, the really important thing that means is that the ratio of caregivers to elders, people who need care, is shrinking. So today it's about 5 to 1 potential caregivers. These are, if you divide the number of elders by the number of caregivers by the number of elders, there's 5 potential people. Not that all of them actually give care. In about 20 years, that's supposed to fall to 3 to 1. And of course, if you think of 3 people there's no guarantee that one of those 3 is going to take care of you. So the pool itself is shrinking, which means the actual number of caregivers is probably much less than 1 by then. And this is a problem that a lot of people see. Already 1 in 3 US adults does informal care of the elderly annually. So this is a problem that people actually see. Not only the demographic trends not look too good, the money doesn't look too good either. So as of 2000, the amount of money that was paid for informal care, all told, is approaching about $275 billion. Out of that, a small chunk, about $30–40 billion of Medicaid. Another $125 or so billion is non-Medicaid, out of pocket. So people actually paying for care. And a big chunk is actually people taking care of their own family. So for instance, if not many people took care of their own family, we didn't have enough, that whole green part would have to be borne by taxpayers. And of course, the need for these things is projected to go up. I haven't put the green part on those things. And the budget, it's pretty much projected to remain fixed, or might be even go lower, I don't know. So given the current mode of care, we are unlikely to be able to afford it. And this is what people mean when they say care is broken. And what you'd really like to do is to really maximize the amount to which family members can take care of their loved ones, to reduce the need for care from the elderly, and then if you actually need care, reduce the cost of care. And that's hopefully where, one of these things is probably hopefully where technology can help. If you look at the cost of care, and this is kind of a breakout from the typical independent assisted living facility. These are actually an independent living facility, so this is a kind of apartment that you can move into and you get care. A good chunk, the biggest chunk of their cost by far is labor. And what this really says is when you take care of someone, what it really means is you kind of have to be there. This is just the high touch speaking up right now. And when you look at the cost, there's 2 kind of modes of cost, modes of care. One of them is so-called supervisory care. This is what the majority of people have, large numbers of people. And this is mostly kind of keeping an eye on people, helping them out with small tasks, visiting them, let's say, an hour a week or a few hours a week. And the cost of this is typically around $200 to $500 a month. Then there's kind of, it's reasonably bimodal. Then there's the assistive care mode, where you really are not able to do any of your day-to-day functioning, and you have to have somebody there most of the time to help you with almost all of it. And you suddenly jump to this $2,000 to $5,000 a month band. For most people, $200 to $500 a month even is actually not all that affordable, especially when you're elderly. And certainly assisted care is out of the question. Now, what do these caregivers do? What are you paying for? After talking to a whole bunch of caregivers, operators of these facilities, CEOs of some of these companies, the real estate folks who built some of these facilities, we kind of came up with a matrix of what care is actually all about. And you can kind of stratify it using kind of a time hierarchy based on how quickly you need to respond. All right? So right at the top, our so-called emergency services, where you really want to respond in seconds. And these are things like, mom's fallen. I hope somebody's there right now. Mom's out of the house and wandering about. This is kind of mild dementia, dementia of any kind, and medical emergencies of any kind. So in these kinds of situations, you want somebody to be there immediately, and the perceived value is actually pretty high. You are actually willing to pay quite a bit for it, but it definitely comes at the cost of perceived liability too. So if you don't get mom quickly and something happens to her, you're going to be sued. So as you go down the spectrum, a big one in the middle that we hadn't quite kind of realized the extent of is adhering to prescribed regimens. So adhering to medication regimens is kind of well known to a lot of people. It's an important thing that the elderly and all of us need to do. But it turns out that this is jointly with the University of Washington, we made a list of about 200 other kinds of regimens that doctors prescribe that elders go home and do. So these are things like use lotions for eye care, tooth care, kind of care of dentures, use of cane, wound care, application of topical ointments, and there's a whole list of these things. And the interesting thing about this stuff is if you don't do these things, your long-term care situation gets escalated to acute care or medical care. It becomes much, much more expensive. And typically, you're supposed to do these things within, let's say, an hour window or so during the day. So you want to intervene within, let's say, minutes up to an hour and kind of make people do it at a particular schedule. A lot of the elder care work so far has been focused on kind of the hour, are you doing a key day-to-day task, also called activities of daily living. So this is are you drinking, eating, performing personal care and all that. And you're talking about responding within hours. If mom doesn't have a lunch, as long as you get her for dinner, that's fine. Then there are other things like weekly and monthly tasks, and it kind of goes down the hierarchy that way. And people have talked about, and there are actually products out there that look at trends over time. Is your current behavior stacking up badly against long-term trends? And one thing to kind of take from this whole thing, so this really is the heart of care. This is what people do. This is what caregivers do. This is what you pay money for. It's all about monitoring and responding to elders' activities. So when you talk about falls, wandering, medical, taking your medicines, cleaning your teeth, drinking food, bath, all these things, it's really about knowing what the elder is doing and helping them with that. So this kind of activity, kind of recognition, monitoring, help is at the core of long-term care. So what can machines do? There's two ways in which you can care, as I've alluded to earlier. The first one is supervisory care. And supervisory care is where the elder, for the most part, is able to do their tasks. And right now, the cost of that is about $200 to $500 a month. So let's say, for machines to start getting interesting, you want to get to, let's say, about $20 to $50 a month, about 10%, to have game-changing kind of change in cost. Can you actually help substantially in supervisory care at $20 to $50 a month? That's kind of the basic question there. And the kinds of things that the machine would do is, log the activity. What did they do? How well did they do it? What was wrong with the activity? All the way to kind of prompting elders through activities. There are research systems right now that prompt elders to wash their hands, for instance. And as you go down this kind of hierarchy, it becomes more and more difficult for a computer to do these things. So there's this basic question, right? I mean, there's big money involved here. Apparently, the reason that it's so expensive is because things are manual. So why, normally when there's a big manual bottleneck and lots of money involved, companies rush in and try to make a lot of money. I mean, Intel, Microsoft, IBM, Siemens, and all these people. So why has it not happened yet? And it's mainly because there's a hard, reasonably unsolved computing problem that's kind of underlying care, which is even activity monitoring is bleeding edge research. When you get to assistive care, which is actually doing stuff, this is the domain of robotics, right? I mean, if you want help giving mom a bath, if you want the system to give mom a bath, you have to have something do it. And of course, it's actually much more difficult because robotics perhaps is even strictly more difficult than perception. And on the other hand, I mean, there's a fair bit more of money involved. Again, if you take the 10% rule, you might be able to have a service with $200 to $500 a month. There's a lot of huge businesses, such as the cell phone business industry, that run at $20 to $50 a month. So the prospect of getting $50 a month from a billion people or a few hundred million people Most companies, pretty much all of them, would jump at it. So this is still an interesting game. So in the rest of the talk, what I'm going to do is I'm going to first look at a case study where we look at a supervisory care scenario. And I kind of abstract away some ways in which the system worked in that case, and some big ways in which the system didn't work. What's the gap between a system like that, which is fairly typical of the research state of the art right now, and what you need to get to 1 billion people. And then I'll point out some research advances over the last few years that help you kind of bridge those gaps. I'll talk about a new case study, a piece of work that we've done at Intel Research over the last couple of years, which seemed to move things forward quite a bit, but there's still quite a lot left, and I'll actually conclude with the way ahead, with what's left to do. So the first case study is something called context-aware medication prompting. Now, it's actually well known that taking medications is non-adherence to medications is only second to heart disease in terms of bad outcomes in the US population. So medication adherence is known to be like the 2,000-pound gorilla in terms of monitoring people and kind of getting value from that. I mean, it's not that adherence to other regimens is not valuable. In fact, most of it has not been studied, but the drug industry has studied the medication adherence in great detail. The CFO of Walmart, when she visited our lab, mentioned that of Walgreens, every 1% increase in compliance of medication compliance in their customers resulted in something like a $200 million boost to their bottom line, simply because they sell more medications. So they've looked at it very, very closely. So the idea behind the context-aware medication prompting study was that the claim that context-aware reminding can improve medication adherence relative to time-based reminding. And time-based reminding is simply, if you're supposed to take a particular medication 3 times a day, there are a lot of solutions on the market that you can buy that will beep very loudly 3 times a day. And they've actually been shown to be reasonably effective too. But our ethnographic work at Intel showed that you're still leaving quite a bit on the table. And the big kind of things that happened, that the residual non-adherence was because people, for instance, were not at home while they were supposed to take this medication and the beeper went off. They don't happen to be close to the med, so the beeper is going off and I'm in the garden, for instance, and I'm busy in some way, especially I'm either sleeping or on the phone. So the study was fairly simple. So all we said is, well, if you're going to leave your home kind of close to the medication window, we're going to remind you and say, hey, take your meds or take your meds with you. We'll wait till you're close to the meds, at least maybe in the home or typically in the same room, before we ask you to take it and prompt you. And we won't prompt you if you're sleeping or on the phone. We won't restrict ourselves to prompting you while you're sleeping. If you're sleeping, then we need to prompt you when you wake up. And this was kind of a fairly large effort with 10 to 12 researchers, engineers, ethnographers, and so on. And the way we did it is, we put a bunch of sensors in the home. So for instance, motion sensors to figure out, which room the elder's in, kind of super duper medicine box in which the elders actually put their medicines so that we know whether they took it or not. Some magnetic read sensors to know whether they're opening the front door, a pressure sensor to know whether they're in their bed. So this kind of a setup is fairly typical for so-called ubiquitous computing kind of sensor-based experiment. And on the other side, to process the sensor data, we had a fairly typical graphical model, in this case a dynamic Bayesian network, that processed the data and then figured out what your location was and whether you're leaving the home or not. Those are the 2 big things that we're trying to classify. And based on the results of that, we would prompt using a deterministic kind of prompting scheme. So no fancy planning in this case. So the results were pretty promising. The rows of these correspond to the different elders. You'll see there are only 6 of them, and I'll get to that soon. But so the way it works is we had a baseline where we had no intervention at all. And in this case, there was about 56% adherence. So the elders in our population, these 6 folks, were actually taking the medication about 56% of the time. When you actually added the time-based prompting, we saw a boost that corresponded to what people see in the literature, to about 63%. And when we added the context-aware stuff, so waiting till they're ready and all that, you get to about 73, 74%. So there's clearly some kind of boost happening here. Certainly these are not statistically significant results, given the size of the population and so on. But fairly encouraging, and if you look closely at the data, they do look quite real. On the other hand, we actually started with 14 elders in this small pilot, and we only got data out of 6. And basically, for many of the elders, the baseline period was so long because of glitches in the system and having to re-engineer things while things were moving along, that a bunch of them actually dropped out during the baseline period. On the other hand, the good news is once intervention started, they didn't actually all drop out. So it seems that it's not the intervention that drove them out of the study. But this is a fairly well-resourced study that happened over many months with lots of engineers from Intel and so on. So although these are encouraging results, my message, the big message that you really get from that is that approach, however we characterize it, really is not the one that's going to help 1 billion people. And I'll go into some detail as to what is actually missing. So the first one is simply that it was actually highly custom. So we had particular notions of what kinds of context, what was preventing the elders from actually taking their medications. And it was actually by no means clear that for other elders, it could be other kinds of context that was important to them. So in some cases, it might be meals, for instance, and so on. And our system was very highly custom built. It is very difficult to actually change it. And in particular, what that means, for instance, is we had the Bayesian network. We had engineers who over some time were trained to build these kinds of Bayesian networks. And every time we had to kind of add it to kind of bring in some new parameters and play around with it, consider new factors, it was kind of it was quite a long process, basically. The structure of the Bayesian network can be changed, and because of the way the conditional independence works, kind of understanding what's happening actually happening there, even for fairly highly trained engineers, was kind of a trial and error process. So once you kind of figure out what the network looks like, something that works, the inertia is to kind of stay where you are. The other piece, of course, is that this doesn't go beyond meds. So if you're talking about $20 to $50 a month, and you do meds and nothing else, you kind of can't amortize over all the other things that you might be monitoring for a person. The other issue was that we had kind of this kitchen sink variety of sensors. And the sensors really depended on being installed in particular ways in particular parts of the home. And this is something that you see often, for instance, even in home security installs. So where you just are putting IR motion sensors around the home. Often inexperienced users will put it in ways where they don't cover the whole room and so on. So even in that simple case, you have people going in and putting those sensors. And another aspect turned out to be the local wireless connectivity turned out to be trickier than expected. So some of the elders, for instance, had systems at home that we tried to leverage. Some of them were actually encryption protected, much to our surprise, but it turned out that the kids had set the encryption, they didn't know what the password was. And then there were billing issues when we worked with actual wireless providers. So the install itself was actually pretty non-trivial. After each elder got their models, in order to get pretty good performance, we needed to do a substantial amount of learning on the models. We needed to re-estimate the parameters of the model. And that, of course, traditionally comes from label data about the user. So myself and a few other engineers spent non-trivial amount of time sitting and actually labeling data in various ways per user. And this obviously doesn't work. And it's a well-known issue in machine learning. And the last piece, I'll kind of bring up the D word. The interaction didn't actually delight. And what this means is, when you think of health and care and so on, you often think of, well, people need it, so it doesn't matter how it looks, and it doesn't matter how it kind of interacts with them. They find it so useful that they use it. But when you talk about these kinds of settings, $20 to $50 and so, and kind of these lightweight settings, the way we interact with the elder, for instance, was we had these little plastic speakers with LEDs on them that you could put around the home. And at a particular time, it would actually beep and say what you're supposed to do. And it is mildly popular, but most of the time, many of them view it as a kind of a nagging kind of an interaction. And we perhaps didn't spend enough time designing the interaction. So there was couple of other big issues. We provided no positive feedback to the elder. So if an elder were actually taking the medication, we didn't say good job or something like that, for instance. And there's a lot of work that says, you should provide positive feedback. It's a good way to get people like your stuff. Another big part that is missing that was explored, for instance, by my colleague Sunny Consalvo at Intel Research is the social aspect of things. So there was no connection at all between this and the elder's caregiver. It was just a closed loop which said, please take your meds. So when you take all this into account, you get something that, what you're shooting for at $20 to $50 is really the magic of the cell phone, which is one of the fastest to get to $1 billion, right? I mean, you want something that's broadly useful for a lot of tasks that a person has. In cell phone, the communication case, there's no real install. You pick it up and turn it on and it works. You can't have this notion where people in the back end are sitting and doing a lot of work per user. Typically, like the iPhone, you really want it to delight. You really are talking about less about a medical system than a consumer system here. So these are all issues that we feel are very important when you try to get to $1 billion. And the first issue of scaling, amortizing over lots of activities, to give you a kind of concrete example of that, when you are a care provider right now, you often fill in what's called an ADL, or activities of daily living form. And you have these classes of activities: make a snack, make a drink, use a phone. And you're supposed to give a score during a monthly visit, for instance, on how well the elder is doing. The thing to really understand is, if you want to know, for instance, how well someone's making a snack, there's no way to do that without really understanding that they're making a peanut butter sandwich, and instead of a jam, they're putting on the pickles, for instance, right? So this seemingly small, innocuous list of activities, class of activities, really translates to being to understand lots and lots of things that an elder might be doing if you want to do, for instance, this fairly routine rating task. The scale issue in terms of being broadly useful seems kind of almost insurmountable. So much to do. So the next part of the talk, I'm going to talk about some simple ideas that we've pursued over the last few years towards actually scaling the activity recognition. Now, so the state of the art for generic activity recognition, scalable activity recognition, is probably using computer vision. So computer vision is probably the most general sensor that, at least in principle, has the information regarding what activities you're doing for lots and lots of activities. And if you could kind of harness that information, you could clearly figure out what people are doing. Now, if you look at a vision-based activity recognition system, it has kind of a fairly standard kind of shape to it. What you have coming in from the bottom, whether it's vision or many of the classic sensors, audio and accelerometers and so on, is some kind of high-dimensional data coming in from the sensors. Almost invariably, there is a step, typically based on some kind of similarity matching, where you've given it some examples, where the high-dimensional, or some kind of a clustering, where the high-dimensional data gets kind of classified into small symbols, basically. So you go from, for instance, a whole frame to maybe the name of an object, such as bottle. You might go from accelerometer data, which is high-dimensional, to a lift action, for instance. And typically in these systems, there's also some kind of a logical or soft rule layer, where typically you can actually, instead of providing with similar examples, which is how you deal with high-dimensional data typically, up there you can provide it with rules or graphical model structure, basically domain information that you just want to tell the system rather than have it learn. So this is kind of a fairly standard structure of these systems. And this picture breaks when you try to do activity recognition. In general, when you try to apply it in the real world, the big problems are when you try to recognize similarities. So for instance, you give the picture of a bottle and you're trying to recognize a bottle. You want to recognize similarity across lots and lots of use cases. So lighting conditions, orientations, perspective, clutter, and all that kind of stuff. And in principle, if you give it enough examples, for instance, and the algorithm scale, you can get there. But invariably, you never have enough examples. So that's no hard problem. The other is, when you classify to something, how do you pick what you classify to? What are the symbols what is it that you're finding out about this high-dimensional signal out there? For instance, a very classic approach in vision is to look at kinematics. So you have cameras in the room. You try to figure out how the person's body is moving, and from that try to figure out what activity you're doing. It turns out to be pretty difficult because the activity, your kinematics, for instance, when using a hammer, might be quite similar to the kinematics when you're chopping with a knife, for instance. and at the top, in terms of the rules, one of the, if you really use that as a way for engineers and domain experts to express their constraints, some of the traditional approaches to specifying these rules, especially the directed graphical models, they're actually not very easy to actually express yourself. The kind of conditional independences that they encode are fairly different from the kind of logical facts that people want to express about day-to-day life. So these are the three bottlenecks, and I'll tell you about some simple approaches that we use to kind of break these bottlenecks in a way that's sufficient for at least long-term care and activity recognition for long-term care. So the basic insight, the first one is, what symbols do we use? So, what logical facts about these high-dimensional signals are we trying to capture? One of our biggest insights was, people's activities, at least for activities of daily living and elder care, are very heavily determined by what tool they're using, what's in your hand. So if you have a toothbrush and toothpaste in your hand, you really don't need a lot of AI to figure out what you're doing. And this intuition is from these slides are from the Invisible Man movies of the 80s. So you have a toothbrush flying around, you have a phone flying around, and you pretty much know what's happening. So we took one hard problem, which is activity recognition, and we kind of reduced it to another old, very hard problem, which is object recognition, at least use vision. But we strongly believe that once you got to the objects, we'd be golden in our domain. We'd be able to pick up thousands of activities. I mean, there was a kind of very strong motivator for us. And the other thing was, we also believe that the objects were so highly indicative of what activity was happening that we could do away with complex statistical models. So for instance, when you wanted to know whether somebody's making tea, and if you wanted to break it down into steps, which you don't always have to, you might indicate that in step 1, you use a kettle and the water, maybe you're boiling the kettle. In the second step, the cup, tea bag, and kettle, because maybe you're pouring it into the cup and dunking the tea bag. And the third one, adding the flavoring. That's the essential information that a person adding domain information wants to convey. And here's a very simple model which basically has one state for each of those steps, one node for each of those kinds of observations, and whenever somebody mentions an object in that list, you kind of attribute a high conditional probability for it in this model. And the point is that for any activity that we cared about, we said, we're going to just do that. We're just going to make a list of those things, and we're going to produce a DBN of this form. There's no messing around with the structure of these things. For generic recognition tasks, that's insufficient because there's a lot of conditional dependencies that's not captured by these things. But we believe that the signal from knowing what object you're handling is so salient that the structure of this thing is not that important. So we traded off kind of the understandability of that kind of interface with the power, the full power of the graphical model approach. So this is not a great insight, but it has to do with choosing the right thing in the middle. And at that point, if our hypothesis is right, well, the models simplify. And the last one is a problem that I've referred. If you have the stack, so how do we do the vision? How do we do basically going from the high dimensional signal to, in this case, figuring out in terms of symbols, what objects you're using? And again, we finesse that problem by actually not using vision. This is where many of you are probably aware, we use this technology called radio frequency identification. And the idea here is very simple. And RFID, the RFID or radio frequency ID works the following way. And actually, many of you have seen this here in the department. You have a tag which is about 40 cents a piece, about postage stamp size. It goes onto the objects, in that case, a bread basket. You have a reader that's close to the tag, and whenever the reader is close to the tag actually tells the reader its unique ID. Okay? So if you want to know whether grandma is using a toothbrush, and we've actually done this with elders, you can put radio frequency tags on the toothbrush and toothpaste. The innovation here is we made a reader that can actually fit on your wrist, and it looks even better than that now. And the idea is simply that when you reach out and touch something, the reader actually tells you what you're touching. You're straight to the symbolic level. So you're not ever dealing with the high-dimensional data. And once you have this, of course, so you have an end-to-end system, and you can then try out, see if we could actually test whether our hypothesis was correct. I mean, does this make sense? And in fact, it did make sense. So we took that activities of daily living list, which is about 14 classes of activities, boiled down to about 65 instances of activities that we looked at. So for instance, in making a meal. We had making a sandwich and making oatmeal, some of these instances. And over 3 months, it took us about 2 weeks to instrument a home with, I think, 120 or so of tags, because we entered in 65 activities. We had 14 people, non-researchers, come in, each person perform a bunch of activities, about a dozen or so in random order, and we tried to figure out what they're doing. And the bottom line is, because we know what they're touching, for pretty much all these activities, we can tell with fairly high precision and recall what they're up to. And the middle column is instructive, because that's the prior work. So in the past 15 years, how much work is there where the activity recognition on that class has been evaluated on a non-researcher, on not one of the grad students involved, for instance? And there's not a lot. And each of these are kind of point solutions. So the point here is, if we are willing to cheat in all these different ways, we can actually succeed in filling up that column, which is actually essential before you can even proceed in elder care, if towards the goal of scaling for non-point solutions. One of the cute things we showed is, once you have those models and you start getting data from mom or grandma, you can actually improve those models without any labeling or examples at all from the user, using standard semi-supervised learning techniques on graphical models. You get about a 25% boost on the accuracy rate that you had before that. So not only can you kind of capture domain-specific information, you can give it a nice little boost by looking at real data. All right, so that's kind of, that captures the philosophy of, so in terms of, if you want to break through these long-standing bottlenecks and try to get towards scaling, what are some of the tricks that you need? And that is a list of them. And I'll now talk about the technology for long-term care project that I led for the last year and a half or so, where we tried to take some of these techniques and push them back and see how well they worked in the real world. And I believe we are installing or have uninstalled the last person this week or next week. We're almost all done here. It's given me a lot of gray hair. All right, so the study goal here was to basically show that activity monitoring technology of the kind that I pointed out. It's all very well to talk about RFID tags and bracelets and this and that. There are huge questions in people's minds about, well, can you really put this stuff in real people's work, homes and get it to work? And the idea here was to show that indeed you can get it to work and it can reduce their perceived burden of care. And that was what we wanted to show. Now, this is again, a pilot study. So we had 12 elders and 12 informal caregivers, formal and informal caregivers, family members and informal caregivers. We were hoping to have 20 to begin with. And we wanted 8 of them to come from nurse practitioners, but the company Swedish, we were actually partnering with Swedish. Swedish got out of the long-term care business during that period. So we had 12 plus 12, and we're doing another, the VA will be kind of doing a follow-up study on this. At least that's in the pipeline. So the idea is for 3 months, put the sensors in the elders' homes. The homes are spread out all over Seattle, so it's reasonably kind of representative. That's I-5 down the middle of what would happen in a real deployment. And jointly with our product group, Digital Health, Intel has a health product group, the VA, which is the largest provider of long-term care in the country, and Europe Health Sciences, let's design the study and see what happens, with the idea that if it looks promising, we can do a lot more. And here's what we deployed, right? So here are the sensors. That's what the bracelet now looks like. It looks very much more like a watch. We put about 10 radio frequency tags in each person's home. About 10 of these so-called shake sensors. A shake sensor is basically a mote with an accelerometer in it. You can put it on a door or a microwave or a fridge. And when you move those big things, you get a byte saying that object was moved. In both cases, we're talking about object use. The accelerometer, the bracelet also has an accelerometer in it, which allows it to keep track of how the elder is moving. So object use plus elder motion goes to the home PC where we do the inference. We send it off to a website. And from the website, every hour, we send an hourly update to a photo frame that's in the caregiver's home and also in the elder's home. So here's a close-up of the photo frame. It's a commercial photo frame. I think costs about $100 and something a pop now. And we're actually pushing 4 kinds of information. So at the bottom here are actually legs. So when you see a leg, that means that grandma was actually active and ambulatory, as they call it. And when you see a gap here, in this case between 11 p.m. and 8 a.m., it means that she was not moving. In this case, of course, she was taking a nap. Sleeping. up on the, so this is the last 18 hours of grandma's, of mom's life, of the subject's life. On the top half are these apples, which say when did they actually either prepare or have or consume food. So this person tends to browse around 8 o'clock, and then she got up around 7 and then had some breakfast around then. At the top right-hand corner is personal care. So this is brushing teeth, combing hair, toileting, makeup for women, and shaving for men. That icon turns black if you've done your morning personal care, the one at the top. The PM icon turns black after you've done your evening personal care. And the little bottle kind of out there, let me see if I can use the mouse. The little bottle has to do with vitamin C consumption. So it's a proxy for medication consumption. So that turns black if you've taken your vitamins. And you have the last 5 days summary here on this side. So if it's black, that means you did the activity. If it's white, you didn't. And what we tell the caregivers is, if you see mom's display having a lot of white, you want to start talking to her, or any white actually. And that's updated once an hour. Elder sees it, a family member sees it, and it's tracking, in this case, 8 activities. And it's very flexible as to what activities he needs to track. The models are all defined, as I said. They're just lists of these objects. So there's nothing very fancy about the way we're doing the inference in the back end. So the first one is that TLC is actually perceived as useful. So we have all these quotes from the subjects, elders, the formal caregivers, and the informal caregivers. So the elders say, for instance, I think it's a marvelous thing. My sister will call me up and say, I don't have any apples. So apples are icons that say that she ate. Why haven't you eaten? Okay, so these are concrete ways in which people are finding it useful. Another elder says, it reminds me, hey, I didn't take my vitamins today. I sometimes get up from reading and figure out I haven't brushed my teeth, and I'll go and do it. So there's a lot of quotes of this kind, which made one of our concerns, of course, was that elders wouldn't be really looking at these displays often enough to get value from them. But it seems not to be the case. And in fact, when we visit elders, it's not so surprising why. They have a fairly kind of relaxed lifestyle where they're sitting around watching TV, and it's not like they're kind of running around doing 101 other things. So in fact, each time one of these picture frames updates once an hour, and it actually pushes a new picture to them, they actually eagerly await it. They're actually looking at it. And so they find it useful in concrete ways. So for the formal caregivers, these are people who are paid to take care of the elders. It's helpful. Every shift I have to sign off that he took his medications. When I sign his form, I know for sure, because before he would tell me that he took his meds. So in this case, this lady realized that the person's medication taking is correlated with their vitamin taking. And of course, we had to put a lot of caveats, and we had to explain to her that, we really are not tracking, pretend we are not tracking the medications, we're only tracking the vitamins. So this is a little bit of a mixed testimony, but in another case there was a lady who was supposed to assist an elder to brush their teeth every morning. And they had this kind of tug of war where the elder would always claim that he brushed his teeth. But when the caregiver actually visited, she had kind of olfactory evidence, the smell, that he really clearly had not brushed his teeth. And of course, she couldn't quite put it that way. And she said that he was much more amenable to the display telling him that he hasn't done the task than her telling him that. So there's all these kinds of dynamics that come up. Family members, this person said, it's like a huge light lighting up the living room. So at first we thought this was about leaving the display on bright and her living room was kind of lit up. What she actually meant, it turned out, was that she sees it as a light lighting up her sister's living room, in the same sense that she can see what's happening in her home. But in particular, before I'd call to check in on her, now I can ask her why she hasn't eaten. So the dynamics change. Other people have recorded this too. When people have specific information, you have better interactions. There was another person who, in her case, her sister had her day and night inverted. So she was sleeping all night long and sleeping all day long, and was awake during the day. And although this lady lived about just half an hour or 45 minutes away from her sister, she didn't know that this was going on. And she used to dutifully call her at 10 a.m. every morning and get this really grumpy sister. And this had been going on for like months. And they figured out, I took a couple of looks at these things, and she said, I figured out what was going on, and she just calls her late at night right before she goes to sleep. So, these seem like simple things, but, the display itself is simple. So, the big question we had was, whether this kind of simple input would be perceived as valuable and whether people would be able to act on it. And there's a lot of examples of this kind which say that even this level of simple feedback can actually be perceived as useful. The other big concern we had was about ease of use. So we are actually telling somebody to wear a bracelet. In particular, we are telling the elder every night to charge the bracelet, plug it in, and every morning to unplug it and put it on. And we had huge concerns. Most of these people are above 75 years old. We had huge concerns of whether they would actually do it. A, whether they'd be kind of capable of doing it regularly, and B, of course, whether they'd want to do it. Because conventional wisdom in our product group, for instance, was that this kind of thing just cannot be sustained because they've tried it before. When we looked at the numbers, they'd actually, most of our elders had wanted in aggregate over 95% of the days. And we had actually at that point, so this was about halfway into the study, lost, we never lost a bracelet due to not being charged. I believe that changed toward the end of the study for some of the subjects. We had some people who didn't allow to discharge. Now, what is different about it? Of course, we spent some time designing so that it was easy to wear and so on. But talking to the elders, it seems that one of the biggest issues here was that through that display, we actually give the elders feedback. So when you wear the bracelet and move around, you get these little legs that say that you're moving around. It's like proof that you did your exercise, and your caregiver knows that you did that. And there's this dynamic where you're used to it. You come in the morning, you don't see the legs, and you go back and put your bracelet on. So again, this is stock, probably HCI 101 kind of stuff. But what can I say? HCI 101 works, I guess. It turned out to be pretty useful, and I think that's a big reason why we got very high adherence rates for wearing the bracelet. The last thing I want to touch on is that we wanted to make this thing delightful. So within the constraints of this kind of thing, what does delightful mean? And what we ended up doing is, other than spend reasonable amount of attention designing the interface, and it's probably subjective whether the interface is still delightful or not. The big thing that we did was something fairly simple. We pushed in these images. Once an hour, we would put in we'd push through a new image. It's just a very simple thing. So this cat here actually was like the superstar. All the old ladies wanted the cat. So these images cycle through once every few weeks, and after the cat came through, we'd hear back from the elders say, "Oh no, darn, I'm not going to see it for another 3 weeks or whatever it is." But and there were other pictures that they loved, and so the feedback. So one lady actually asked us for pictures of a pot-bellied pig. I love it. It's interesting. I wish I could get the cat to come back, so I just want to mention that. It only comes every week. I love the pictures. I love the animals. I like a pot-bellied pig. I look at the animals and the legs. It's fun to look at. And the point here is we really are moving from what's kind of a gray medical device to a consumer device. I mean, these things really are potentially iconic things. As important, the iPhone of the 75 plus set. And you can mix communication, fun and care, and there's an opportunity to kind of be had here. And by making it delightful, of course, is how you get it to scale to very large numbers. If it's just viewed as a medical device that's monitoring you, I bet a billion people are not going to buy what you have to sell. So the first big question is, moving beyond instrumented environments. Right now, we are looking at a small set of things about a person that we can track. But if you compare that to the set of all things that people do, there's still a whole bunch of things that we can't handle for various reasons. And for instance, even with the radio frequency tags, we can't tell, for instance, how an object is being used. We can't confirm that a particular action was done using, for instance, video and so on. So there's this whole question of whether we can do, we can basically get much better coverage. So we have accuracy as long as you're in the home. Can you actually get coverage to much broader piece of people's life? And I just want to point out a project called the Everyday Sensing and Perception Initiative, ESP, within Intel. It's a pretty big effort, 12 researchers distributed around labs in the country. And the goal is to understand 90% of your day with 90% accuracy. The big push is around mobile sensors. And one of the big tricks that we're trying out is we're going back to vision. And we're using a so-called egocentric camera. So you have a camera on your shoulder, on your lapel, looking out. And for instance, it's focusing just at figuring out who's in front of you, focusing just at what's in your hand, and using, for instance, that egocentric perspective to localize you very, very accurately. And we have preliminary results over the summer which show, for instance, that it's, recognizing what's in your hand once you figure out where your hand is much, much easier than recognizing an object that's generically in your room, for instance. Face recognition, because you're figuring out somebody's in front of you, works quite well. So this is pretty exciting. What we're really saying is you can take a little camera, plug it into your iPhone, walk around the real world, And anywhere you go, it can figure out what you're doing, who you're interacting with, and where you are with very high accuracy. The other thing is, this business of typing the models, it's nice and all, but there are lots and lots and lots of things about the world that people care about, and they're related in all kinds of different ways. So for the last couple of years, we've had a project called Knowledge-Rich Perception. Kind of the motto is, read, and read as in or in its unit system. Read the web, read stuff, convert that into some kind of a logical format. Watch the real world, and this is what's new about it, and understand what's happening in the real world. So the big picture here is take the web, use know-it-all, for instance, to suck in the web in some logical format, convert it into an actual probabilistic logical format using, in our case, something that looks an awful lot like Pedro's Markov logic networks. And you get something like this, a network of facts about the world. In our case, we have about 50,000 kinds of things about the world right now. We are kind of, with Oren, kind of pushing it up to about 5 million things. And when you look at these common sense facts about the world, when you read and understand things about the world, a lot of them, for instance, are grounded in things that you can observe. For instance, it's grounded in use observed can of soda. So a lot of common sense, for instance, is grounded in the kinds of objects that you use. Of course, if that's the case, if you have sensors to observe those things, you can actually use these big networks for inference. And we've actually shown that you can actually read from the web, get real world data from people, and infer what they're doing without any human interaction at all. So massive kind of common sense from the web, read, watch, understand, with no human in the loop. So the last piece, the last little bit here is moving beyond proofs of concept. I've been talking about 6 people, 12 people. We've done other things with 10 people in the past, 20. How do you move beyond a proof of concept? And the big message here is, we've been focusing on the technology aspect of things. It's well known. A lot of people have observed. There's all kinds of things that need to come into play before you can show that this works end-to-end at large scale. Service delivery, these are public health school, medicine. How does it interface with acute care? Who pays and why would they pay? How do you make them more amenable to paying? How do you design spaces so that this is easier to do? Housing, public policy, and all that. So the big message here is, because we're kind of a little bit of a clearinghouse over here in the Seattle area with sensors, there have been at least a dozen or so research groups from the health sciences. Pharmacy, health, public health, dentistry, a bunch of others who've come and said, given us actually projects where we use behavioral monitoring to kind of address care. And they're the domain experts in kind of all these areas, would like to figure out that it kind of works in a holistic way. And UW and Seattle is one of the very few places where all these things converge. If you're interested in this stuff, this is a great place to do this stuff. Come talk to people in the lab. A lot of the professors on campus and in our department, machine learning type folks, are involved in some of these things. It's a great opportunity. So to end, to take another quote from the article of Gawande, in the story of Jean Gavril and a geriatrician, there's a lesson about frailty. That aging can occur in 2 ways. One is early and precipitately, very quickly, with old age of enfeeblement dependence, sustained by nursing homes and hospitals. So this is a scenario that you want to avoid. The other way is more gradual, preserving for as long as possible the ability to control your own life. In this case, of course, he was viewing this as, what can doctors do to help elders, and what can elders themselves do to kind of be in this mode? And one of the ironies, of course, is the way you might be able to maintain a lot of this control is perhaps by ceding some of it to machines in this new age where machines may care. So thanks, that's it. Work was done with a lot of interns, a lot of faculty, many from UW, a lot of my colleagues from Intel. Would like to especially thank the lab directors of Intel Research, who are, you may or may not know, drawn from the department. Gaetano Borriello actually kicked off a lot of the activity recognition work that I talked to you about using RFID and so on. James Landay was really the force behind saying, look, you should probably hook up with some of these healthcare professionals and the VA and the state and all that, try to make this something bigger. And David Weatherall has actually shepherded the project to hopefully its conclusion this week.
I was wondering if you had looked at the long-term aspects of actually allowing people to know when they've done things or not. So you say it tends to make them more aware of a failure to execute a routine or something they should be doing. And that's the fact that they're reminded all the time makes them more learn a routine or get into a routine that they didn't have before. So if even you remove the device or the system, they still gain benefit from it.
Right. So we haven't looked at it, but this is one of the big open questions in any type of prosthetics, actually, and not just kind of computational prosthetics. There's a whole question of, do you get dependent on the prosthetic? Is it a temporary phase where when you remove the prosthetic, you can actually do well? In terms of the cognitive aspects of things, it's unclear that cognitive prospects have long-term effects in terms of, you work with them you use it for a little while and there's sustained improvement over a long time. I don't believe people have shown that. So we certainly have not looked at it, but this is a very valid and standard question when you think of any kind of helping system. Yep.
So a lot of the applications you focused on have been sort of peace of mind type applications. Do you have any thoughts on how you would start enabling assessing the quality of these ADLs? Because the chart that you showed was, there's a series of things that you have to detect. So detecting it is one thing, but assessing the quality, how well they do it over time, seems like a more important thing that you might want to consider.
Right. So we've done some work in that area. So the question is, right, when the elder performs an activity, how do you know that they performed it with high enough quality? And it's a much more difficult problem, as you can imagine, than just knowing that they did it. In particular, you have to kind of figure out what are the important details. You may not even be sensing the right amount of detail. And then there are algorithmic question about, what does high quality mean? So one of the things that we had looked at is, looking at quality meaning, a high quality execution of an algorithm given your sensors is a bunch of examples that you have of good executions. And then looking at things like outliers as to, is a particular execution far away from the examples that you have, for instance. But there are very specific questions that immediately come up. If you say that an activity was not done very well, you immediately want to know what is wrong with it, which part of it was bad. And we had some ideas on how to do that, which we've written up, but it's not an area that's been looked at, to my knowledge, a lot.